it is, whatever it is. But here, those possibilities cannot be entertained because the parents were told that the patient is having, the child is born with a heart disease. So we have to think of a heart disease where the patient can present with gross right heart failure. Abstinence, I think we have to keep in mind. That is a possibility we have to keep in mind, because they can present with right heart failure, one. And if there is an obstructive type of abstain, they can develop early cyanosis, and all these things can happen. So that can be in our mind. Any other possibility?
VSG with early isolation, VSG.
Abdominal distension. For abdominal distension, you need significant elevation of the right side pressure. Uniform elevation of right side pressure.
So can it be Lutembecker type?
Lutembecker will not give rise to cyanosis.
Yes, sir.
Because cyanosis is not a feature of Lutembecker.
Yes,
they can have a torrential left to right shunt, but cannot develop cyanosis.
Yes, sir. Yes, sir.
Anything in our mind where anything where there is a right-sided problem which has given rise to all these complications? Can it be
endocardial cushion?
Endocardial cushion defect. Usually, this is not the presentation. They will be more. Their initial presentation will be more with breathlessness, palpitation. Here the presentation is no palpitation, nothing. So I think we are stuck here. I think one possibility we'll definitely think of, which you also suggested, is a abstinence anomaly with some obstruction of the tricuspid valve. I think that is something which we can think. Another situation where the abstinence can have gross tricuspid regurgitation is when there is an anomalous attachment of the anterior tricuspid leaflet to the RV outflow, which will actually cause some degree of RV outflow obstruction. And when there is RV outflow obstruction, the tricuspid regurgitation, tricuspid, all those things will be grossly exaggerated. So, any other right-sided lesion I'm thinking of, because here the child recently has presented with right heart failure. Okay, shall we go ahead with the physical findings and then go to discussion? Any other possibility anybody would like to raise? Okay, right. Yes. Go ahead. Yes.
So can we still put as a last diagnosis TOF or?
Tetralogy fellow usually presenting as abdominal distension. All those things will be unlikely. Then
15 years he has survived.
15 years survivor is not a problem for tetralogy fellow, but presenting with abdominal distension and gross right heart failure, not the usual feature, because it has got an outlet. So when the right side is having some problem, it can shunt the blood to the left side. So they usually do not develop that much of a abdominal distension, all those things. And usually the right atrial pressure is not grossly elevated also, because the RV can decompress to the LV, and hence the right atrial pressure will not be grossly elevated in patients with tetralogy of Fallot. That is why JVP elevation may not be detected in tetralogy of Fallot. Because and also cyanosis was noticed only at the age of 80 years ago. Even though the patient was told that yes, there is a congenital heart disease, but the parents noticed cyanosis only around the age of 6 or 7. Is that right, Egnath?
Yes, sir. Yes, sir.
Oh, okay. So that also must be.
Can it stenosis over the period? Sir?
Yes.
Can it be, sir, progressive pulmonary stenosis over the period of years, sir?
Pulmonary stenosis usually presenting with abdominal distension, ascites. That actually tells me that there is some obstruction to the tricuspid flow. There is some problem because the right atrial pressure has to be high. I agree with you that sometimes these patients with severe pulmonary stenosis can develop cyanosis because of the foramen ovale can open up, and they can have severe right heart failure. I think that we will consider severe pulmonary stenosis resulting in gross right ventricular hypertrophy, elevation of the right atrial pressure, opening up of the foramen ovale, and giving rise to right to left shunt. Patient is becoming cyanosed. I think that possibility we will also consider because it's a purely right side, mainly right-sided problem. Okay, right. Any
But
other?
sir, isolated PS is a very isolated PS is very
Very?
considering isolated PS as a differential diagnosis is not. There has to be some combination also.
What combination?
ASP with
No, yes, because when there is isolated pulmonary stenosis significant, that can give rise to significant right ventricular hypertrophy, that can give rise to significant elevation of the RV diastolic pressure, and that can result in RA pressure elevation. So a chain of reaction is possible, but I also agree with you that we cannot keep first on the list, but definitely we can consider as a differential diagnosis. And also the heart lesion was detected early, so obviously there is a loud noise. See, when there is a noise only, then the doctors quickly pick up the heart lesion. So the point that before discharge from the hospital, the mother was told that there is a heart lesion. Now cyanosis is nothing. So obviously there is a noise going on, and because of that noise, the pediatrician might have diagnosed heart lesion. Subsequently shown to the cardiologist. He also confirmed it. So from the story, we have to consider that the child is having a loud murmur.
Shall I continue, sir?
Okay, right, yes. Anybody who would like to raise any other point, we can consider that possibility also. Any other point, any thought process? Mostly we have to think of a right-sided problem which has given rise to cyanosis. Because the history is more like a right-sided problem. Of course, there is a history of exertional breathlessness that can also be part of the right-sided symptom. Okay, right. Now we'll go ahead. Yes.
On general examination, patient conscious, cooperative, oriented with the time, place, and the person, moderate to bit, moderately nourished. Then the center sinus is present on skin, lips. A great thick clubbing is present in all four limbs. A pitting type of pulmonary edema is there. Then back and spine is normal, no morphinoid feature, no dysmorphic feature. Temperature is normal by palpation. Pulse 90 per minute, regular with normal force. Volume, tension, no radiofemoral delay. Normal conduction of normal condition of the artery wall. All peripheral pulses are palpable. Blood pressure 110 by 70 right upper limb, 112 by 70 left upper limb, 110 by 70 both lower limb. Respiratory rate is 16 per minute. It's thoracic abdomen. Sorry, actually in typing mistake. SpO2 is 86% in all four limbs. GVP pulsatile, prominent A wave with the normal descent with mean GVP pressure of 3 centimeter above the sternal angle in 45 degree of angulation with normal respiratory variation. Abdominal jugular reflex is absent.
Okay, wait. Anybody who would like to from Eknath, would when you got these findings, what are the things which crossed your mind? Like to ask one question. What about the Y descent? Normal descent. Okay, all are normal descent. Okay, right,
Yes,
fine. Yes.
only prominent A wave is there. Sir.
Yes. Okay. Any point from this point that's prominent A wave? What are the conditions in which you get a very prominent A wave? Saroj?
Yes, sir. Prominent A wave, it means that the IVS is intact, possibly. And sir, and the right ventricular.
Well, you cannot say the word IVS is intact. You can only say that there is no evidence of a unrestricted ASD. That's all.
IVS, sir. IVS is intact.
Okay, right. Yes.
Sir, so possibilities are there may be, sir, right ventricular systolic pressure or right ventricular diastolic pressure is high, like in cases of pulmonary stenosis.
Okay, very good.
Sir, it may be, sir, because of the sir, RV, Sir, in RV failure, usually V wave is more prominent, sir. But and sir, from the left-sided also, sir, we can get prominent A wave. Sir, the Burnham effect.
Left-sided A wave. What do you mean by that?
Sir, no. So left-sided heart disease causing prominent A wave due to the Burnham effect, like in cases of aortic stenosis.
You mean reverse Burnham effect? But are you considering a strong left-sided disease stronger in this patient? Because
no, sir. Tricuspid stenosis, sir.
Oh, I think we have to think of the possibility of an abnormal tricuspid valve also, where even in Epstein's anomaly with an abnormal tricuspid valve, you can get a prominent A wave. That's possible. That has to be kept in our mind.
Yes, sir. And sir, one more, sir, though it is, sir, only prominent A wave if present, sir, RSOV2 RV.
Oh, I think because 8 years history of breathlessness, I will not consider that.
No, sir, I am just telling prominent A wave cause.
Prominent A wave can happen when there is a when the sinus vessels were not ruptured, but why it bulges into the right atrium and obstructing the tricuspid valve. I agree with you. Sometimes the sinus vessel aneurysm can, especially coming onto the right atrium, can bulge towards the tricuspid valve, interfering with the tricuspid flow, and then patient can have a prominent A wave. That's right. Yes. So either tricuspid valve disease or some disease which has resulted in pulmonary arterial RV hypertrophy, like pulmonary stenosis, should be kept in mind. And pulmonary stenosis goes fitting because it fits in with our other observations that the child was detected a heart lesion before leaving the hospital, obviously meaning that most likely there must have been a loud noise. If the child is not cynosed and there is no noise at all, and then very unlikely that somebody who is examining the patient might have diagnosed a heart lesion, unless somebody has been very careful in examining. When in a busy general hospital, sometimes without murmur, without cyanosis, sometimes heart lesion may be missed. That is why sometimes VSD sometimes may be missed on before discharge from the hospital, and later the patient can come with the symptoms. So I think possibility of pulmonary stenosis can still be in our mind. Yes. Okay, I think we'll go further. Yes, Egnath. Yes.
On inspection, chest is ellipsoidal in shape with bilateral symmetry without a localized bulge outer retraction. Trachea is in central. Apex impulse in fifth intercostal space in mid-clavicular line. No visual impulse seen. No scars, sinuses, or dilated veins. On palpation, apex is situated in fifth intercostal space in mid-clavicular line, shifted downwards and laterally. LV types. Palpable P2 is
LV type. Yes.
Okay. Palpable P2 is present in the second left intercostal space. Grade 3 left parasternal hue is present. No thrill.
Wait. Go one. Grade 3 left parasternal hue is present. No thrill. Any thought process? Because grade 3 parasternal hue present means our Epstein's anomaly is out. Because patients with Epstein's anomaly cannot have a grade 3 left parasternal hue. Grade 3 parasternal hue means there is a significant pressure overload. Palpable P2 is present in the second intercostal space. So that obviously means patient is having
pulmonary
patient is having
pulmonary hypertension with left type LV type of apex.
Yeah. So LV type of apex with the pulmonary arterial hypertension. What are the possibilities in your mind? So LV type of apex with the cyanosis. What are the conditions? We have discussed that previously. Egnath, what are the? Yeah.
So truncus arteriosus one. Then DORE with unrestricted VSD.
Yes.
Then
Tricuspid
atresia. Yes.
Tricuspid atresia.
Yes.
Endocardial cushion defect. Single ventricle.
Single ventricle. And endocardial cushion defect with the significant mitral regurgitation.
Mitral regurgitation.
So These are the few conditions which can out of, but this patient is having severe pulmonary arterial hypertension. So what would be the possibility with LV apex of these?
Then endocardial cushion defects.
Yes, I think endocardial cushion defect is a strong possibility because the patient has developed the features of pulmonary arterial hypertension. The patient has got LVI type of apex, and then the cardiomegaly is not very significant, borderline cardiomegaly. So that also goes in with the development of pulmonary arterial hypertension. The patient has got cyanosis. All put together, I think we will start thinking whether it could be a AV canal defect. Yes. So what about pulmonary stenosis?
LV apex not going in favor.
No, LV apex is not in favor of. Okay, right now we'll go ahead.
On percussion, liver balance is present in right fifth intercostal space, immediate line. Left heart border is correspond to the apex. Right heart border is 1 centimeter from the right sternal border. Then on auscultation, S1 is normal. S2 is a close split. P2 is loud. Sorry. Ejection click heard, which is high pitch, sharp clicking quality with maximum intensity in the second intercostal space. Grade 3 ejection systolic murmur best heard in the left intercostal space, non-radiating, short, early picking, harsh, increase with inspiration and supine, decrease with expiration and the standing. Grade
well, let's wait. It is with increasing on inspiration. Okay. And on supine. It decreases with expiration standing. Early peak. Okay, right. Yes. Okay, go ahead.
Grade 2 early diastolic high pitch decrease endo murmur in the second intercostal space, non-radiating, best heard in leaning forward position and decrease with the expiration.
Is it audible on the left side? Oh, sorry, right side.
Yes, sir.
This murmur, is it audible on the right side? This early diastolic high pitched decrescent of murmur.
It's left second intercostal space.
That's right. You see, I am asking a question: is the murmur audible also on the right side?
Not, sir.
No, not on the right side. Okay. Okay. Now, if we ask Egnath, he knows the diagnosis. So, Saroj, at this level, or Gaurav, would you like to give some comments?
So here looks that patient has got a ejection click is present, and
yes.
so it may be, and looks like coming from the pulmonary valve. It may be valvular click or it may be a vascular click.
Okay.
And from the murmur, sir, it is increasing with.
Out of this, do you like to have any information to differentiate between ejection click, valvular click, and vascular click?
Yes, sir. With whether it is varying with the respiration or not.
Yeah, whether it is a basic click or a constant click.
Constant click, sir.
Yeah. Egnath, was it a basic click or a constant click? The ejection click that you heard, was it a constant click or was there a basic nature?
It's a constant.
It's a constant click. Okay. So it's a constant click. Yes.
A constant click means vascular click.
Yeah, it's a vascular click, and most likely it is related to elevated pulmonary artery pressure. Okay, very good.
Sir. And so the
grade 3 that already he has told a grade 3 that is there, sir. Parasternal heave is there, so it has to be pH.
It has to
grade
be
3 heave. More likely to be pH. They have written that grade 3 parasternal heave is there. So
yes. So the RV pressures are high. It can occur in because this patient is having pulmonary regurgitation. Obviously, can it be absent pulmonary valve? But then pH cannot be explained. Okay, right? Yes. Clinically, what are things at this stage? What are the things that you will cross your mind?
Dysplastic pulmonary valve.
Or why do you want to say it's a dysplastic pulmonary valve? Dysplastic pulmonary valve will not give rise to any ejection click. And in dysplastic pulmonary valve, mostly it is stenotic, and they will not give rise to significant pulmonary artery hypertension. Don't think of a dysplastic pulmonary valve here. I think from the valve, what are these two murmurs that he has described?
So the first murmur, it is looks like pulmonary stenosis.
What did you say is a pulmonary stenosis? He has described that it is a short and early peaking.
So flow murmur from the pulmonary valve.
It's a short early peaking murmur, and so it could be a flow murmur. So okay, that's right. Second murmur.
The second murmur is pulmonary regurgitation murmur.
Yes, it looks like a pulmonary regurgitation murmur. Can pulmonary regurgitation murmur also can give rise to a flow murmur across the tricuspid valve because there is a larger volume of blood coming to the RV during diastole, and that is being pumped out. And on top of that, diagnosis that we were thinking was that whether it could be a AV canal defect. In that case, the patient can have some degree of shunt across the intrathecal septum onto the right side, and that can also increase the
flow through the pulmonary valve.
Yes, and also these patients with the AV canal defect are prone to develop early pulmonary artery hypertension, Eisenmenger syndrome, and so that also fits in with this particular age of this patient. But the only point is that distension of abdomen and all is a bit unusual. They can have cyanosis, all these things, but abdominal distension, whether we have to think of some more pathology, some more abnormalities, we have to keep.
Tricuspid valves.
Yeah, we have to keep in our mind. Okay, right? Yes. Egnath, we'll go ahead. So electrocardiogram now. Before that, okay. So we have thought of the possibility of an LV dominant situation where there is a evidence of cyanosis and all. So I think we have, that's why we thought of the possibility of a AV canal defect. Okay, right. Go ahead with the ECG interpretation. Egnath, you can interpret the ECG.
It's a 12 channel. It's a 12 lead ECG with normal standardization.
Okay.
Rate is around the 80. Axis is around minus 30, 35.
That's also a point that is in favor of AV canal defect.
Yes,
That's a left deviation. How will you? What are the electrocardiogram features of left anterior vesicular block?
Sir, there is a QR pattern in one AVL and RS pattern in 2-3 AVF with the left axis deviation.
Okay. More, if you wanted to put all the points, you should say that there is a QR pattern in lead 1 and AVL, in which the Q and R are more dominant in AVL than in lead 1. It should be more dominant. That is clearly seen. You can see that the AVL has got more deeper Q wave and a taller R wave. Second is that there will be an RS pattern in lead 3 and AVF, where the R and S in lead 3 will be taller or more prominent than the R and S in AVF. And the axis will be minus 32, anywhere between minus 32 to minus 90. So all these criteria must be looked into before you say that the patient is having left hand atrial block. Sometimes patients with the inferior myocardial infarction also can have a left axis deviation because of the influence of Q waves. But then you should look at all the criteria, the QR pattern in lead 1 and AVL, where the Q wave and R wave will be more prominent in AVL than in lead 1. 2, RS pattern in lead 3 and AVF, where the R and S will be more prominent in lead 3 than in AVF. And axis is minus 30 to minus 90. So here all the criteria are satisfied. So the patient is having left hand atrial block. Okay, right. Yes. Anything else?
Sir, gross LVH is also there, no, sir?
Sir, LVH is there, LA is also enlarged, and sir, T waves are very peaked.
Is there an LA enlargement?
Only
Sir, in V1, sir, there is a biphasic P waves, and sir, notched in lead 2.
I may not immediately diagnose left atrial enlargement from the electrocardiogram. I agree with you that there is a small part of the P wave in V1 is negative in some of the tracings, but that is not enough to diagnose left atrial enlargement. I won't diagnose. Yes.
In presence of LVH, whether this much is important or not.
No, you cannot have LVH.
Okay.
No, I won't agree on that because
Okay.
there's a criteria for left atrial enlargement that is not satisfied.
Yes.
Does it fit in with our original diagnosis of or not original in between diagnosis of AV canal defect?
So going in favor, sir.
Many things are in favor, but I would have been happy with the patient had associated right bundle branch block also.
Also, sometimes complete heart block as well.
Sometimes they can have complete heart block, they can have right bundle branch block. So that is not there, but other things are again there. The evidence of a left ventricular hypertrophy. There is evidence of right axis deviation, left axis deviation, axis around -30. So all points are in favor of a AV canal defect. Okay. Right. Any other comments? Gaurav, would you like to give any other comments? Any doubts to be raised?
Only left-sided chambers appears to be enlarged. Right-sided PH is.
That's with gross. That is a bit odd because the patient is not.
Yes, sir.
As you rightly said, the patient has got significant parasternal lift, very significant, grade 3 parasternal lift, and
Yes.
there is a murmur which we thought of the possibility of that this could be a pulmonary regurgitation murmur. All those points are when we consider with electrocardiogram slightly odd.
LV strain is there more. I thought RV strain will be there, but here LV strain is here.
Yeah.
And left axis.
So should we think of any other possibility? Should we go to single ventricle?
Yes, sir. I was also thinking single ventricle, and JVP is also not corroborating with the findings. JVP is almost normal only with 3 millimeters.
But there's an A wave in the neck that you have to explain.
JVP was around prominent A.
There's a prominent A wave in the neck. That also is a point against this gross AV canal defect. Very unlikely to give rise to prominent A wave. They usually more often give rise to V wave because there is a mitral regurgitation as well as tricuspid regurgitation, and that usually contributes to a V wave rather than an A wave. So at this stage, what should be our thought process?
I think single ventricle patients age also he is surviving, so single ventricle will.
Because survival in a single ventricle
can be up to 40 years. Can be up to 40 years.
No, but single ventricle with because there is no evidence of pulmonary stenosis because the murmur is early peaking murmur. So in that type of patients, and also cyanosis noticed only at the age of 8 years or 6 or 7 years. So before that, there was no gross cyanosis. Single ventricle, the patients will be cyanosed and it will be detected quite early in life. So there is something more that we have to diagnose. Otherwise, everything cannot be explained because RV is not seen at all here.
Yes.
Clinically, but there is a gross parasternal lift. So that makes us start thinking that whether this could be a single ventricle. That also we'll have to keep in mind.
So whether that parasternal lift is confused with the LA expansion?
No, if you try to find out whether the LV apex and the parasternal lift are continuous, so did you try to find out whether it is continuous? Is there a LV apex and then there is a gap and then the significant parasternal lift?
No, I didn't get it. Sir. I'm not able
Sir,
to.
but that cannot be confused with grade 3. No, sir, grade 3 will be very prominent.
Grade 3 will be very prominent. So now I was thinking whether how to explain this grade 3 parasternal lift with no ECG evidence or hypertrophy at all. Everything is LV.
So in case of so this one endocardial cushion defect, the AV valve regurgitation is very significant. That's why, sir, there may be, sir, up to grade 3 it may go.
No, see, whatever may be the thing, when there is a grade 3 RV lift and we are thinking of the possibility of significant RV enlargement, there is evidence of pulmonary regurgitation also. So, an ECG not showing any RV forces, that according to me is very odd. Is there a Q wave in V1? No. There's a small Q wave seen in V2. But no Q wave in V1. I cannot make out a Q wave in V1. Anybody having a thought process? What may be the possibility? Okay, now we'll go ahead then. X-ray chest. Eknath, can you interpret the X-ray chest or?
This chest X-ray PA view with lips apex is left-sided.
It is a levocardia. Yes.
Yes, leocard. Then, sir, the peripheral allogram you can see here, sir.
Now, you have to make a comment about the cardiac enlargement.
Some cardiomegaly is there, sir.
The significant cardiac enlargement. You should comment about the chamber enlargements.
Then there is right pulmonary artery that is enlarged.
It seems the right pulmonary artery is enlarged. Before that, you can make a comment left quarter. What about the aorta? Is it prominent? Is it normal? But what about the pulmonary artery segment? Is it dilated? Is it normal? Left atrial appendage, is it normal? Then you have to comment about the rest of the left quarter of the heart. You should also comment whether the right border is enlarged, the right atrium is enlarged. Then you should comment about if you can get an idea about the arch of the aorta. In every congenital heart disease, you should look at whether it's a right-sided aortic arch or a normal left-sided aortic arch, and then you can come to the pulmonary vasculature, whether there is a reduced pulmonary vasculature, increased pulmonary vasculature, is there evidence of pulmonary artery hypertension? So that's the way you have to go. So can you read the X-ray once more?
Chest X-ray PA view.
Okay.
With showing a mild mild to moderate cardiomegaly.
Yes, I think it's maybe more than mild because it is the left border is almost touching the lateral, the costal rib, and also there is some extension of the right border of the heart into the right hemithorax. So I would consider that the cardiothoracic ratio may be near about 58 to 60%. Okay, right. So
appears to be upturned apex also, sir. I will go with RV. Upturned apex, not an LV type.
I agree with you that it is not an LV type, but
it is an RV type.
And it is not the classical RV type also. RV type, you expect the apex to be lifted up, as can occur in a patient with tetralogy of Fallot. But here it is not like that. So it is difficult to be certain, but it is definitely not LV type where the apex should be dipping down. Okay, right? Yes.
Then
what is that prominent thing that you are pointing? What is the prominent thing?
This one, sir.
Yeah.
Left pulmonary artery.
Or is it left pulmonary artery or pulmonary artery segment?
Pulmonary artery segment, sir.
So it's pulmonary artery segment. So pulmonary artery segment is grossly enlarged, so indicating that something has happened. What are the situations where you can get prominent pulmonary artery segment? Eknath?
In case of pulmonary hypertension due to the
increased pressure. 2. Increased?
Sir, sometimes severe pulmonary stenosis, sir, then post-stenotic dilatation.
Yes, post-stenotic dilatation.
Sir, absent pulmonary valve.
Yes, that is a absent pulmonary valve with AS, PS and AR, especially in a patient with the tetralogy of Fallot. When you find a pulmonary artery segment is prominent, especially main pulmonary artery segment is prominent, you should think of the possibility of absent pulmonary valve. Okay, yes. So 4 conditions you should suspect. They are: 1, increased flow, increased pressure, post-stenotic dilatation, and also in some other patients with idiopathic dilatation of the pulmonary artery. So here, what may be the reason? Is it increased pressure, increased flow, or both? Egna,
It's increased flow.
why did you say increased flow? The right pulmonary arteries?
It's dilated, sir.
Yeah, the right pulmonary artery is significantly dilated, and from the appearance, it seems that you can see a few endon arteries, indicating that there is a evidence of increased pulmonary blood flow. Okay, so that is there, and looking at the periphery, is it cut off? So from an X-ray chest, you diagnose pulmonary artery hypertension by finding that the central vessels are very huge, large, and then peripherally it is cut off. Do you think that there is a peripheral cutoff, or you think that the peripheral vessels are also as prominent as the central vessels?
It's cut off.
Yeah, I think the central vessels are very prominent, while as you go to the periphery, the vessels are less striking and less prominent. So a possibility of shunt lesion developing pulmonary artery hypertension, something like Eisenmenger physiology should be thought of. Yes, okay. But what is the condition which in a Eisenmenger there can be a gross cardiac enlargement?
With sir, RA also prominent, sir.
Yeah, RA also is enlarged because if you look at the vertical height, it's almost 3. So there is a
then ASD, sir.
RA enlargement. Yes, it is RA enlargement. And also, usually when the patients with PDA or VSD develop Eisenmenger, the heart size comes back to normal. But in a patient with ASD, it can still remain enlarged. So you have to think of an ASD situation where the patient has developed some degree of pulmonary artery hypertension so early in life. So that the one in which this can happen is associated with AV canal defect. The most important point against the ASD is it's all LV, electrocardiographically. That cannot explain the atrial septal defect. So we are stuck at that level where the ASD cannot explain the whole thing. We need something more. So I think still we have to think of the possibility of a single ventricle before we go away from that, because the patient is, in spite of the cardiac enlargement, RV lift, parasternal lift, the patient is not having any electrocardiographic evidence of right ventricular enlargement. Mostly it's all LV. Everything is LV. Okay, any other thought process? Gaurav, would you like to say a very interesting case?
Sir, I was thinking ECG of the same patient or?
It's the same patient.
What do you mean by that?
Because everything else is going.
Sir, but ostium primum ASD is favoring, sir, both this one, sir, X-ray also, sir.
No, ostium primum ASD also, whatever may be the thing, you cannot escape RV. Whenever there is ASD, RV has to be there.
And sir, X-ray also RV only, I am thinking. RV is
I will be diplomatic in commenting that it is an RV type of apex, but I will not agree on LV type of apex. So I would say that I may find it difficult to comment whether it's RV or LV type. LV it should dip down, RV it should look up. Both the patterns are not there. So you cannot classically say whether it is an LV type of apex or an RV type of apex. But cardiac enlargement, pulmonary segment is prominent, evidence of shunt lesion, right atrium is enlarged. All those points are in favor of an associated atrial septal defect. But then why there is no VST, there is no RV? So that is why I thought we have to think whether this could be a single ventricle, because RV forces are not seen at all. We are not able to see RV forces in the electrocardiogram. Everything is LV. Gaurav, anything else you want to give a comment?
He had RV failure as a primary.
Yes. Yes, presented with the girl is presented with the RV failure. Recently, she has developed RV failure because for 8 years she was having exertion breathlessness, but the main features of RV failure occurred about 1 or 2 weeks ago with distension of abdomen, edema of the lower limbs, all those things. Okay, now let's go to the echocardiogram, which should give us a. Saroj, you please interpret the echocardiogram. Or Gaurav, would you like to do?
Anyways, TOF we have ruled out. It is not TOF, sir, because
it is not TOF. Cardiac enlargement, shunt,
so TOF. Yeah.
everything is pulmonary segment is prominent. There is no X-ray evidence of TOF at all. Gaurav, would you like to interpret the echo?
Yes. It's a parasternal long axis view.
Okay.
With aortomitral continuity is there, sir. I can make out the aortomitral continuity is there. It is.
It's not yet clear to me, but mostly I think there's a continuity. Okay, yes. There's some degree of
mild. The mild MR is there. Mild MR is there.
Yes, it's not a gross MR. Yes.
But there is no interventricular septum. There's no interventricular.
There is the VSD seen, sir.
VSD is.
That's too early for us to comment about that because we have just seen only. Actually, it is not a very good parasternal long axis view because of the gross cardiac abnormalities. The parasternal long axis view also is distorted. Okay, right. Let us look at the other views also.
Interventricular septum is not very.
Yes.
Short axis view at the pulmonary wall.
No, look at the whatever is the images are there. You interpret it.
The short axis view focusing on the.
There is some turbulence across the pulmonary wall.
RVOT.
So pulmonary regurgitation is present.
Yeah, there's a significant pulmonary regurgitation can be seen. Very good. Yes. Is there pulmonary stenosis?
Sir,
Some turbulence is there, sir.
And sir,
Only turbulence.
main pulmonary artery is dilated.
Yeah,
Branch pulmonary artery also dilated, sir.
Right pulmonary artery is grossly dilated. Main pulmonary artery also significantly dilated. Yes. Okay.
Yes, sir.
Yes. Okay, let us look at this view.
4-chamber view. So 4-chamber view.
What about the tricuspid valve?
Yes, sir. Tricuspid valves are atretic.
No, atretic.
Tricuspid valve is atretic. We are not able to see any tricuspid orifice at all.
Now, sir, it is seen.
Well, let us see. Now I could not see. Here it appears as though there is no tricuspid valve, or even if it is there, it may be a point, pinpoint tricuspid valve, whatever is seen in this one. And I can see a intraventricular septum also. Okay, right, yes.
It is a LV type only, sir. The more we can say it is a LV type because.
Yeah, I think let us look further. Any other views, Eknath?
Yes, sir, I will just. This is the pulmonary artery.
Pulmonary artery.
It's a dilated, sir.
Yes, grossly dilated. Yes.
Then this one is a permeativity, so no obstruction.
Yes.
This is actually so gross VSD is there, sir. Actually, I have got limit.
That's a large VSD. Okay, yes.
Yeah. So and patient has severe pulmonary hypertension. Actually, it's around some 85, 86 was there, sir.
Oh,
hypertension.
Yes. Clinically also, there was evidence of pulmonary artery hypertension, but the only thing is that in spite of pulmonary artery hypertension and pulmonary regurgitation, RV is not there. So,
sir, in this view, sir, actually, this septum is completely absent, sir, actually. Some small is there only. And initially, it was looking a single ventricle, actually, sir.
oh,
So, but after that, we noticed some septum is there, some basal or some apical septum. And then we diagnosed as a, ventricular septal defect and like that.
with hyperplastic right heart.
Mm.
Because let me see, could you see the opening of the tricuspid valve? In this view, I am not able to see the opening of the tricuspid valve. Was there any opening of the tricuspid valve?
Sir, and actually, tricuspid wall actually normal, actually, this patient. No? Actually, a little bit.
No, because in this view, can you run it? Because I am not able to see the opening of the tricuspid valve.
No, actually, sir, it is some, some.
Is there a better view to demonstrate the tricuspid valve opening?
Sorry, actually, sir, actually, I got
Okay.
limited. It was there, sir, in machine.
Yeah, so tricuspid valve was opening normally. Okay, right,
Yeah.
yes.
Here, sir, we can see it's opening normally, sir, actually.
Oh, it's a tricuspid valve, okay, right, yes.
It's opening, sir, it's a mitral wall, and it's a gross, actually, VSD is there, sir, actually, because. And actually, that ECG, we also got confused why the LVH is, it was showing. Sir, actually, the LV non-compaction was also there, sir. So does it cause, sir, LVH?
This LVH have agreed, but then we have got a clinical finding of gross grade 3 parasternal lift and there is no RVH. See, when there is a such significant gross RV parasternal lift, I would expect the electrocardiogram to pick up some RV forces. It is not there.
So LA is normal here, sir. LA is normal.
Yeah, LA is normal.
So
LA is slightly in the parasternal long axis view. I thought there is some degree of LA enlargement, but not grossly enlarged.
So that cannot be mixed with LA enlargement. Parasternal lead. That cannot be LA.
No, it is not like LA. Here, you are saying that this is the inverted septum, and then there is the other one is the tricuspid valve. Okay. Do you have one more view, or this is it?
No, sir, actually.
Okay. So okay, you can read the echocardiographic findings so that we are clear.
So actually, patient has a VSD actually, sir. It's a long.
There's a large VSD.
VSD.
We can actually even consider as a single ventricle because
yes, actually initially we kept a single ventricle, but there was some some dilemma whether it's a single ventricle or the gross VSD, sir. Actually,
here looking at, I would consider there is a large VSD because there is a rudimentary intraventricular septum is seen. Yeah, okay, right, yes.
Then mitral and tricuspid all completely absolutely normal, sir, for that.
Okay, yeah. So
then on pulmonary artery was grossly dilated.
Yeah. And our tricuspid valve is opening to, is it opening towards the left ventricle or is it opening to the right ventricle?
It's opening the right ventricle.
Yeah, it looks like it's opening to the right ventricle because if the other one is whatever you have shown is the intraventricular septal defect, then the tricuspid valve is opening to the right ventricle. Okay, right? Yes. And is there a tricuspid regurgitation?
No, sir. There was no tricuspid regurgitation.
No tricuspid regurgitation. So how are you going to explain the prominent RV lift? And what is the reason of this patient having a prominent A wave in the neck? Because the tricuspid.
Due to shunt reversal there, sir.
Shunt reversal is there, but then when the tricuspid valve is absolutely normal, when there is a shunt reversal, that may not give rise to prominent A waves in the neck. Especially there is a large VSD, so that the end-diastolic pressure in the RV can be decompressed to the left ventricle. That's a bit unusual. Then you need to have some more explanation.
Sir, can this echo be like, sir, single ventricle with rudimentary RV, sir? Because, sir, that which we are thinking VSD, that may be like, it looks like a, sir, in the 4-chamber view, the tricuspid valve was so much bright and, sir, not opening well.
Yeah, yeah.
And
In that view, I thought that there is now the tricuspid valve is either not opening or it just got only a pinpoint opening.
sir, a single ventricle with rudimentary RV is also, sir, possible. Sir.
That can explain most of the ECG findings and everything that we have got.
Yes.
But here, it seems that there is a small intraventricular septum, especially towards the apical portion. That may not be very important because I think for all practical purposes, it may be behaving like a single ventricle. But then
So history of recurrent LRTI is there, sir. So VST is history of recurrent LRTI is given.
no, that can be explained because there is no pulmonary stenosis. So the patient has got an increased pulmonary blood flow, and that can explain the
in single ventricle also, sir.
In single ventricle also, the whole thing can be explained because as long as there is no pulmonary stenosis, the pulmonary blood flow will be increased, and that can be explained. There is no problem. The problem with us is one or two. One, we have to explain the prominent AVM in the neck. One. Two, we have to explain the grade 3 parasternal lift. And ECG not showing any evidence of right ventricular forces at all. It is not seen at all. It is whenever if this if this ECG is shown to me and then told that it is cyanotic congenital heart disease, I would have immediately gone for tricuspid atresia because there is a left axis deviation, prominent left ventricular forces, and no right ventricular force.
And Q in one AVL, sir. Q in one AVL.
Yeah, yeah. That is what goes with the left-handed heavy block. So, but echo does not tally with that. I was wondering whether all the physical findings cannot be explained by echo, whether there is something more to be looked for. So, of the possibilities, I think the closest that we can come along with the electrocardiogram, XHS, everything is actually a gross, large, or rather single ventricle with practically you have to put as a large BSD, very large BSD for practical purposes, almost a single ventricle. And due to some reason, probably RV is slightly hypoplastic. Because here, for looking at the parasternal apical 4-chamber view, I thought the RV is rudimentary, LV was significantly dilated. And in that view, actually, the tricuspid valve opening also was not very striking.
Like he told, there is non-compaction was also some there, sir. Will that affect?
Yes, actually, everyone
feeling?
got surprised after seeing the ECG because it was not matching with all these findings. So a non-compaction was there.
So non-compaction, will that affect the filling in? If we consider this a single ventricle physiology, that non-compaction, will that affect the filling and can cause that atrial A wave? Sorry, in JVP?
No. See, non-compaction will usually give rise to systolic dysfunction.
Okay, sir.
A wave is a feature of a diastolic dysfunction.
Diastolic, yes, sir. That's a yes.
So non-compaction cannot explain the A wave.
Okay, sir.
Because if you want to explain the A wave, there should be a RV hypertrophy or tricuspid valve obstruction, which has resulted in prominent A waves.
Okay.
And if it is RV due to an RV problem, it has to be RV diastolic dysfunction, and that is the one which can give rise to a prominent A wave, not the systolic dysfunction.
Okay.
So I think everything is not very clear. I think there is some physical findings which, and also the X-ray findings also does not tally, and because in presence of a such prominent RV lift and also a prominent pulmonary regurgitation, absence of an R wave or absence of a RV forces in the electrocardiogram is extremely odd. As Gaurav has rightly pointed out, whether it is the history of a different person. Okay, I think it's a very interesting case. We are left with a few points which we cannot explain, especially in relation to prominent A wave and also in relation to RV lift, where there is no prominent RV lift, grade 3 RV lift, and there is no evidence of electrocardiographic evidence of RV forces. Everything is LV forces. But if it is a single ventricle, yes, many things can be explained. And on top of the single ventricle, if the tricuspid valve also is abnormal, and then that can explain the A wave and all those findings. In the most of the findings can be explained. Okay, right. Any other investigation which can help us? Did you do an angiogram?
Sir, in case of VSD for PH, we can't take RARV gradient in case, no, sir. Or we should take a pulmonary artery gradient, no, sir.
What did you say?
Just had a doubt, sir. Means whether suppose any patient with the VSD, in that case, we need to normally we calculate PA means whether there is pH or not. That we from RVSP will take will say, sir. So, but when there is VSD, so RV may be reflecting the pressure of LV. So RARV gradient won't be correct, no, sir.
What is the problem?
No, so for in case of a large VSD for PH, we'll consider the pulmonary regurgitation gradient only, no, sir?
Yeah, pulmonary regurgitation gradient is enough. I agree with you. Or also you can take the, if you are getting a VSD and you can measure the VSD flow velocity by looking at the systolic pressure, you can get the RV pressure.
Yes, sir.
How is it possible?
Sir, from systolic pressure, we can minus the gradient. That will be the RV pressure.
Yeah. So you take the systolic pressure and minus the gradient, and that will be the RV systolic pressure. So when I have a patient with the VSD, you can calculate the RV systolic pressure by looking at the and if the velocity across the VSD is 0 or 1 or very low, then obviously means RV and LV having same
pressure.
systolic pressure. So that will be the pressure in this patient, because the atrial septum is the VSD is very huge. So the pressure in both the RV and LV should be the same. And by recording the systolic blood pressure, we can get recording the systolic blood pressure is enough to get an idea about the RV systolic pressure, which will reflect the pulmonary artery systolic pressure also. So, so that those things are very clear. The problem is only with the no RV forces in the electrocardiogram.
Yes, sir. Okay.
So that we can explain only if you think of the possibility of some the RV hypoplasia or maldeveloped RV, or we have to think of the possibility of a single ventricle. Here there is some suggestion of a interventricular septum, so single ventricle cannot be strongly entertained.
Yes, sir.
Okay. Now, what will you do for this patient? Can we do something, or we feel that
final diagnosis? Yes, but final diagnosis slide. Final diagnosis slides.
Yeah, whenever you have done an echocardiogram gives you the structural diagnosis. So we are unable to explain some of the ECG findings, but we cannot go away from the structural diagnosis. My diagnosis would be looking at the whole thing. Tricuspid valve seems to be normal. Mitral valve seems to be having some degree of mitral regurgitation. There's a large VSD, and maybe almost equal to a single ventricle, and maybe that the right ventricle is slightly hypoplastic. That would be the way in which I would think, because otherwise I may find it difficult to explain the electrocardiographic abnormality, and also I may find it difficult to explain the prominent AOS in the neck. Anyhow, even if there is a hypoplastic RV and the tricuspid value is normal, it is difficult to explain the AV, because RV can easily decompress the diastolic pressure in the RV can be easily decompressed to the left ventricle. So a prominent AV all means is extremely difficult to explain. But the only way it can explain is that the RV must be slightly hypoplastic, and that may be the reason why there is a right atrial A wave, which is reflecting onto the into the jugular venous pressure. Regarding management, Eknath, what is your thought process about that?
Already patient in severe pulmonary hypertension, sir.
Yes. So,
So we have to go manage the patient with medically only at this moment.
do you think that the medical management is useful? What is your thought process? What is the already? Is there any point in reducing the pulmonary artery pressure?
RV failure, we can.
Yeah, some the patient is in severe. No, is there any point in reducing the RV pressure? No, is there any point in reducing the pulmonary artery pressure? This patient is having a huge VSD. So what will happen? Can the pressures can be different in RV and LV? And the LV pressure will represent the systemic pressure. So I don't think there is any point in giving drugs to reduce the pulmonary artery pressure. It may not be much use because the RV and LV actually behaving like a single ventricle. So whatever is the pressure in the RV will be systolic pressure in the RV will be equal to that of the systemic systolic pressure. So there is very little that we can do for this patient because the patient has severe pulmonary artery hypertension, so the gross structural abnormality, and palliative treatment in the form of the patient is having gross polycythemia, patient is having the pack cell volume is huge, they can develop some thrombotic problems, especially the cortical venous thrombosis. So these patients need a periodic venesection, and that can improve to some extent, quality of life. So periodic venesection is possible. And of course, if the patient is in not severe right heart failure, because he said that there is a prominent A wave, but the descents are normal. So that also is very odd for, is the patient anemic? What is the hemoglobin?
Hemoglobin is around 10, sir.
10?
Yeah.
Oh, there is so she's anemic. So I think improving her hemoglobin may sometimes, so at 10, the patient is having easily detectable cyanosis. That's very, very unusual. Usually when the hemoglobin is 10, at 86%, the patient will not be cyanosed. There is something somewhere we are missing, because when the hemoglobin is at 10, at 86% saturation, the patient won't be cyanosed. At 86% saturation, if the patient has to be cyanosed, the pack cell volume should be around 17. At 10 is very unusual for the pack cell volume with the hemoglobin of 10. At 86% oxygen saturation, the cyanosis is a bit unlikely. Okay, so any thought process about the treatment? I don't think we can help this patient because already there is gross pH. The patient has got a large, almost a VST which is so huge. The patient having something like a single ventricle, gross pulmonary regurgitation. All put together, we can have some palliative treatment. Nothing more could be done. Okay, right? Any doubts? Only doubt is that some of the findings that we have got, especially the electrocardiographic findings and the echocardiographic findings, and even to some extent X-ray findings also, does not tally. That is the only problem. Especially the severe RVH, where the no RV at all, where we are getting gross parasternal lift is a very significant finding which does not correlate each other. Okay, Saroj, any comments you would like to give?
No, sir.
Sir, actually, just one my doubt, sir.
Oh.
Sir, Actually, this patient actually presented, it's become symptomatic around the 8 years of age, and the parent notices cyanosis like that one, sir. Again, sir, actually, so gross VSD is there, sir.
Yeah,
So,
hmm.
does it happen, sir, early ISM injuration like that one, this condition, sir? Anything else like that one?
No, the patient becoming cyanosed by the age of age can be explained by the patient might have developed early. Usually, in a patient with VSD, they develop by the early second decade. But this patient developed late towards the first decade, and maybe that this child may be having some the pulmonary artery pathology, which has resulted in the regression of the pulmonary vascular pressure, pulmonary vascular resistance might not have taken place at all, and the patient might have continued to have pulmonary artery pressure going up and might have developed early ASM migraization. I think that is the only way we can explain it. So there is maybe that child, because it's a single, non-sanguine. It is not a. Is it a non-sanguineous or sanguineous marriage? It's a sanguineous marriage. So they can have some genetic abnormalities. So it's a very findings are. Agna, what is the diagnosis in your department?
Actually, we kept diagnosis as a large VSD with ISM injuration with right heart failure. Actually.
So how did you explain the absence of RV forces in the electrocardiogram?
Actually, sir, that was the some that was controversial. It means no one explained why this RV forces are absent in that.
No, you have to think that it is more like something like a single ventricle with practically no RV forces or a rudimentary RV force. Otherwise, you cannot explain that electrocardiogram.
Sir, actually, this RV is looking rudimentary, and if you consider the single ventricle, then that can be explained.
Yeah, so you have to think of a here, whatever you are seeing here, the RV does not seem to be that rudimentary. That is the problem. And also, you had a physical finding of a gross RV lift grade 3, RV lift with pulmonary regurgitation and all. So really case which is actually stumping everybody. Excellent case, very interesting discussion. So we could look at many aspects of the, but of course, a single ventricle, in the examination, if somebody makes the diagnosis of single ventricle, I will give him credit, because the LV forces, significant cyanosis, then the electrocardiogram did not show RV forces at all. All put together, I think somebody makes a diagnosis from the clinical findings, electrocardiogram and X-rays. If somebody makes a diagnosis of single ventricle, I will go ahead. I will agree with him. But then, of course, you have to think of the possibility whether there is a tricuspid valve abnormality by looking at the prominent airwaves in the neck. Okay, I think that's it. If you have got any doubts to raise, we can. Otherwise, we'll consider it as a we'll. Any point somebody wants to raise or needs some explanation? Okay, what shall we have next week? Shall we have some spotters next week? Or you would like to have a case discussion? Vero, what would you like to have?
Sir, spotters next week, sir, better idea.
Okay, so we can have spotters. We'll consider various spotters like ECG, X-ray, echo, then pressure tracing, and angiogram. Okay, right. Okay, we'll have a spotter, and then week after next, we will go for a case discussion. Okay, right. Okay, thank you. Good night.
Okay, thank you so much.
Thank you, sir.
Thank you, Aganath. It's a very challenging case. Only thing is that we could not explain every physical finding. I think in your department also you had the difficulty to explain
Sir,
everything.
repeat the ECG, sir. If patient is there, I will ask him to repeat the ECG once more. Patient is.
I also agree with you. I think it may be worthwhile repeating the electrocardiogram, Aganath, whether ECG technician has confused or mixed up the electrocardiogram. I think it may be worthwhile doing a repeat electrocardiogram to make it certain that we are not mixed it up. No RV forces at all. Everything is LV forces. Is the name of the patient written?
I think if he has the record, you can call the patient and repeat the ECG. Eknath?
Sorry?
Can you repeat the ECG? You can call the patient and repeat the ECG if it's possible.
Sure. Actually, when patient come follow, we discharge that patient.
Oh.
No, you will have that phone numbers, no? That discharge.
Yeah. We have number that actually we have taken the number.
Then if she is coming, Chengalpet is not a very big city.
One thing that can be done is that if the patient is coming for a follow-up, I think you can repeat one more electrocardiogram.
Sure, sir.
And that will, I think, that will help us to make it certain that we are not mixed it up.
Okay.
Because
yes, large biphasic in V3, V4, sir. Does that explain anything, sir? That biphasic complexity, equiphasic biventricular hypertrophy.
But there is no biventricular hypertrophy. There should be some RV forces in V1. No RV forces at all. Everything is LV. In V5, V6, it's all LV.
Yes.
That cannot be the pattern in a large BST of this nature. But if it is single ventricle, yes, because single ventricle is mostly LV, and the whole will be LV forces. That is why I thought it must be a single ventricle, and whatever we are interpreting it as a small septum may not be an artifact even.
Sir, one question, sir. Like, sir, in case of single ventricle, pulmonary artery origin will be from where, sir?
Usually in single ventricle, there will be a rudimentary infundibulum.
Yes,
and
sir.
pulmonary artery arises from that infundibulum. And in about 80% of cases, single ventricle, it will be the LV, and they may have associated transposition. And the RV, the pulmonary artery will arise from a rudimentary infundibulum, which will represent the small right ventricle.
Yes, sir. Yes, sir. So, sir, in the pulmonary artery, sir, the flow will be also small.
That depends upon whether the patient has got pulmonary stenosis or no. If the patient is not having no pulmonary stenosis and the pulmonary valve is normal, then there will be plethora. Because see, whenever the pulmonary artery is not, pulmonary valve is not stenosed, and if there is a good communication between RV and LV, more blood will flow to the pulmonary artery. Because the pulmonary artery system is a low pressure zone, and large volume of blood can flow to pulmonary artery. That can happen, and these patients can develop pulmonary regurgitation also when they develop pulmonary artery hypertension.
But sir, we have to show that pulmonary artery is arising from the rudimentary RV or infundibulum of the RV.
Yeah. That's usual.
Yes, sir.
That's
yes,
better.
Sir. Yes, sir. Okay, sir.
Okay.
And sir, one more point, sir.
Oh.
Like, sir, this single ventricle is RV type or LV type. How will we say definitely, sir?
By looking at the infundibulum.
Okay.
If you find the infundibulum and it has got no relationship to the ventricle, then you know that it is a
RV
or LV type.
No, sir. A little confusion, sir. Once more.
Yeah, if there is an infundibulum that you can see, and the infundibulum is only connected to the pulmonary artery and has got no relationship with the main chamber, then that will be an LV type of single ventricle. But if the infundibulum is connected to the chamber and there is a gross right ventricular type of a single ventricle, then you will consider that this is that is very unusual. About 80 to 90% of cases of single ventricle are RV type.
LV type.
LV type.
So, sir, pulmonary artery, proximal to the pulmonary artery, we will search for the infundibulum.
Yeah, you should look for an infundibulum.
Okay, sir. And if infundibulum is present, then it will be LV type, sir.
Yes.
Okay, sir. Yes. Okay, sir. Thank you.
Okay, right. I think next week we'll have spot test. Thank you. It's very challenging case where we could not explain every finding. I think Agnad will tell us later if the patient comes back, and then you can repeat the electrocardiogram whether there was any mix-up.
Sure, sir.
Okay.
Okay. Thank you so much.
Right. Good night. Good night.
Thank you.
Thank you, everyone. So, can I end the meeting with your permission?
Yeah, you can stop. Thank you.
Okay, so I'm ending this meeting. Thank you.